In this video, I'm going to be going through pyloric stenosis. The pyloric sphincter is a ring of smooth muscle that forms the canal between the stomach and the duodenum. Hypertrophy, which is thickening and therefore narrowing of the pylorus, is called pyloric stenosis. This prevents food travelling from the stomach to the duodenum as normal. After feeding, there's increasingly powerful peristalsis in the stomach as the stomach tries to push food into the duodenum. Eventually, the peristalsis becomes so powerful that it ejects food into the esophagus, out of the mouth and across the room, and this is described as projectile vomiting. Let's talk about the features. Pyloric stenosis typically presents in the first few weeks of life, with a hungry baby that is thin, pale, and generally failing to thrive. The classic description of vomiting that you should remember for your exams is projectile vomiting. If you examine the baby after they've had a feed, you may be able to see the powerful peristalsis in the stomach by observing the abdomen. A firm, round mass can be felt in the upper abdomen that feels like a large olive, and this is caused by the hypertrophic muscle of the pylorus. If you do a blood gas analysis, it will show hypochloric, meaning low chloride, metabolic alkalosis, as the baby is vomiting the hydrochloric acid away from the stomach. This is a common data interpretation question in your exams, so it's worth remembering this fact. Let's talk about the management. Diagnosis can be made using abdominal ultrasound to visualize the thickened pylorus. And treatment involves a procedure called a laparoscopic pyloromyotomy, which is known as Ramsted's operation. An incision is made in the smooth muscle of the pylorus to widen the canal and allow food to pass from the stomach to the duodenum as normal, and the prognosis is excellent following the operation.